Next session will be unlocking NAFLD and obesity. I would like to request Dr. Deepak Lahoti, who will be moderating the session, to take the stage. I would also like to invite Dr. Kaushal, Madan, Dr. Duseja, Dr. A.S. Dave, and to take the stage. And this presentation would be a pre-recorded one. Dr. Sarin is not able to join us physically. So we'll have a pre-recorded session for the first 15 minutes, then we'll have a panel discussion.
No, Dr. Sarin is very much here on the Zoom. You can see him live. He was not able to come. Dear friends and colleagues, the next topic, as you heard, is unlocking NAFLD, non-alcoholic fatty liver disease, and obesity. Fatty liver disease, obesity, and diabetes, these are the three super epidemics of this century. Of late, it has been realized that fatty liver alone is not the culprit of morbidity and mortality in many situations, and we have to focus more on comorbidities, metabolic dysfunctions. So in fact, non-alcoholic fatty liver disease has been rather modified or re-christened into metabolic dysfunction associated fatty liver disease. So NAFLD has become MAFLD. So today the speaker on this topic is Professor K Sarin. He does not need any introduction. Still, I think it is a matter of honor and pride for me to say a few words about him. He has been father of hepatology in current times, done a lot of research, has huge number of publications, and he has created a world-class institution, ILBS, and we all know him. We have been sending patients to him, we have been consulting him on various occasions, and he has been a teacher for all of us. I want to share that he has been part of the process of re-christening of NAFLD into MAFLD himself, and last year Stanford University selected him as one of the key researchers world over. So it's a it's a point of great pride for all of us in India that he was chosen as a ace researcher. So without wasting much time, I invite Dr. Sarin to start the proceedings. Please start the presentation.
I request Dr. Makkar or Dr. Anil Mota to chair the session.
We have two panelists, Dr. Duseja and Dr. Kaushal Madan. Both are eminent hepatologists. Dr. Duseja is from Chandigarh. He is professor of hepatology, and he has done extensive research work in field of fatty liver disease. And similarly, Dr. Kaushal Madan is a very well-known hepatologist in Delhi. He is from Max Hospital, Saket. Both have served Indian Association for the Study of Liver Diseases in capacity of General Secretary. Dr. Duseja is currently the General Secretary of INSL. So with these words, I hope Dr. Duseja and Dr. Madan have joined. Can we start?
Yes, Dr. Lahoti, I'm there. Thank you.
Professor Sarin is already there.
Yes.
Yeah.
I'm very much there, and if there's a problem in video, I can do that live, but better to have a video, which I had sent earlier.
So just a moment, sir.
Yes.
Dr. Sarin, can you hear us?
Yeah, I can.
All right, thank you, sir. We're just checking the audio here.
So there may be a glitch, sir. Sir, can you help us by starting at your end? I'm so
Okay,
sorry.
I will just locate the slide in a minute and get to you in no time.
Sir, if you can share the slides on your screen.
Okay, I will do that in a minute. Okay.
हो जाएगा? Sir, I think they are successful in doing it. Just a second.
Okay.
Right. So there we go.
Next slide. Next slide. Swati,
Please start the video.
next slide.
Greetings from ILBS and thanks Dr. Lahoti and the team to invite me. I will try and bring some new concepts on NAFLD or metabolic dysfunction associated fatty liver disease. NAFLD, as we used to call it, is seen in 1 in 4 Indians and also countries like India. So red means more than 30% of the population has NAFLD. As you will see here, India is red, like many other countries. The liver cancer as total number proportion by NAFLD is represented here. The maroon is 35 to 40% of all cancers are due to NAFLD. India is a rare country to have NAFLD of that prevalence and HCC. In a recent WHO survey, we found diabetes associated fatty liver is the commonest cause of liver cancer in India. 2 years ago, there was a global consensus amongst few experts. I was fortunate to be part of it, where we changed from NAFLD to MAFLD. What does it mean? A guideline was also then subsequently brought out by a puzzle of change in name and relevance of NAFLD. This is very simple and I want you to take a picture and remember this part of it. Anyone who has got overweight, BMI of 23 and above is overweight, above 25 is obese. He has fatty liver. All diabetics have fatty liver. This is MAFLD. Those who are having lean or normal weight less than 23, now you use the metabolic risk factors, that is waist circumference, blood pressure, TG, HDL, all others. So 2 major categories, phenotypes are overweight or obese and diabetics. Alcohol drinking is common. In the US, normally you will find about 30 to 50% and in some places 66% of the people are moderate drinkers. And this is gradually increasing. Australia and US. People who have been moderate drinking and have NAFLD in them compared to light drinkers, moderate drinkers have higher FIB4 or the NAFS score, the NAFLD fibrosis score. So people who have been drinking and have fatty liver have a poorer outcome. Now therefore, we have a situation where 3 types of people are there. One, who have got pure NAFLD, they are lean, they are younger, low BMI. These people are about 20% or so of the total population. Those who have NAFLD, they are at risk, they have been taking alcohol, and they are MAFLD, but they don't have NAFLD underlying. There is a group of overlap where you have both alcohol and fatty liver. They have insulin resistance and others. So MAFLD basically is a heterogeneous group. It includes lean, it includes obese, and it also includes those who have mild to moderate drinking. Let's look at the real life situation. You have overweight and obese, metabolic dysfunction, type 2 diabetes. If you are using this criteria, which was used in Japan, you will be able to pick up fatty liver in almost all the patients. But if you use the current NAFLD criteria and you exclude alcohol, you exclude others, then you will only pick up about 70% of who pick up. You will miss fibrosis in mild and moderate, which are now included in part of NAFLD. So where are our approaches to a fatty liver? If a patient has fatty liver, you will divide them whether he is heavy alcohol, hazardous alcohol, then it is a different journey. But if he doesn't have heavy alcohol, mild or moderate, then you will say, well, he has NAFLD. If he has all other underlying diabetes or metabolic syndrome of obesity. Those who have heavy alcohol, in them also, we have to now think, is the alcohol-associated fatty liver disease is dominant or it is not? So if you find the alcohol-associated fatty liver disease is dominant, then you have to have dual pathology. Obese plus heavy alcohol. This is a dual pathology, and both alcohol and fatty liver are present in this. Another patient has dominantly obesity or metabolic function. That is another group of patients. And third is a group where you have pure alcohol as dominant. Much more work has to be done, but now the approach to steatosis is clear. What does fat do to the liver? There is a surplus fat in the liver where there is a high ALT and extrahepatic organs are also involved. Let's look at this. Either alcohol, mild or moderate, or fat in the food, it causes steatosis if it is more than 10% of fat in the liver. The immune cells will then find out these fat-containing hepatocytes. They will try to kill it. That is steatohepatitis, which will lead to further scarring to heal, that is fibrosis, finally cirrhosis. Fatty liver disease generally would have high ALT because of steatohepatitis. Once there is a fat in the liver of more than 10%, insulin cannot get in. The hepatocytes are unable to function. Then more insulin is produced, and finally there is diabetes. So in a way, diabetes is a liver disease. Further, this fat will spill out into the blood as high cholesterol or high triglycerides. So when a patient has high TG or cholesterol, we just give statins or fenofibrates or something to decrease them without treating the cause, which is in the liver. So hence all dyslipidemics have fatty liver. This fat causes atherosclerosis, hypertension, heart disease, stroke, gallbladder stones, and all types of cancer. So this all is included into metabolic dysfunction associated fatty liver disease. So NAFLD or MAFLD, it causes increase in inflammatory cytokines, insulin resistance. Additionally, the adipose tissue is also dysfunctional. There is more necrosis, there is insulin resistance, there is lipolysis, fat-containing macrophages move from there. So this vicious cycle of insulin resistance, cytokines, lipotoxicity continues, and this leads to organ damage. Obesity, of whatever reasons it is associated with all the conditions as you can see. Primarily NAFLD the complications. How do you assess NAFLD? There are three parts: fibrosis, fat, and inflammation. Ask yourself or your patient, ask them to learn, find out 10 things in the history: metabolic syndrome, diabetes, blood pressure, heart or kidney disease, liver disease, gallstones, cancers, obesity, snoring, polycystic ovary. So 1 of 10 is good enough. That guy needs assessment for fatty liver. Weight, normal formula is height minus 100. So 170 minus 170 kg would be 170 centimeter tall person. For female, 170 minus 105. With this, you can pick up most cases. You may need ultrasound to find out and fibroscan sometimes to see fat and stiffness. Simple ALT can help lipids and blood sugar. You all are aware of the gap values: 220 upper limits, 250 you start having fatty liver, 306 means 30% or more fat. And fibroscan with 40 milliseconds will show you stage 2 or more fibrosis. This is the algorithm which primary health care, people who are referring you need to teach them two simple things. FIB4, if it is less than 1.3, no worries. Yearly regulatory evaluation. But if FIB4 is more than 1.3, then this patient is an intermediate high risk group. FIB4 is age, AST, and platelet, ALT. So 4 things are needed. You can also go into other risk scores, but I have a lot of faith in FIB4. After doing this patient has FIB4, let's say 2, you need to take him for fibroscan. Fibroscan, very simple. If it is 8 or above, it is intermediate to high risk, stage 2 or more fibrosis. He will need a biopsy, he will need therapy, saraglitazole or whatever for he is low risk, then once a year or maybe 6 months, and change lifestyle will help. How do you manage MAFLD? First, remember there are 4 phenotypes: all obese, all diabetics, all metabolic syndrome, and then 20% of your patients, which are 3rd generation in a way, are lean or normal weight people. These are high risk, and these patients develop tumors fast. The management of NAFLD today is also based on our phenotypes. The classical NAFLD, if it is obese, you will ask them to lose 7 to 10% of the weight. You will ask them to change their diet and exercise. Diet should include coffee and low fructose. Drugs as of now are metformin, liraglutide, some gliptins and SGLT2 inhibitors. Very heavy, you used to do balloons or change gut microbiota. Those who are lean also should lose about 5% of the body weight and rest of the things as shown. Another group of patients who are diabetics or who have diabetes with NASH and now will be under MAFLD, you have to give drugs for diabetes management, lipid lowering, MAFLD measures, and gut microbiome. These patients have to be followed for development of tumors. Compared to hepatitis B, the MAFLD is 3 to 4 times higher risk of NCC, especially if the AST/ALT are high. Also, development of cirrhosis, decompensation is faster. As a specialist, you and people who refer to you ask them to change their approach. Fatty liver, don't say kya farak padta hai. No, you have to say liver fat is an alarm. A healthy liver, you have a good diet and exercise. But as you have fatty liver, you have to do weight reduction. Remember an important part, there is a reduction in fructose. Mediterranean diet, or I would now say Indian diets, should have high fiber, we don't eat fish regularly, high veg and low cholesterol or sugar, and coffee 2.2 mugs a day. This is the benefit of weight reduction. Very low calorie diet is 600 kilocalories. In the beginning, this patient had about 13% of liver fat. 600 kilocalorie in 4 weeks' time, he comes to about 5% fat, which is acceptable. This is to show you using MR elastography and others. This in the beginning is 36% fat. But on very low calorie diet, you can see it has come down to like 2% of liver fat. You can use in patients who are immobile or cannot exercise an intragastric balloon placement. Intragastric balloon is just a smaller, easier and reversible method of placing a balloon in the stomach, which we regularly use now, not only for non-cirrhotics, but most often now for cirrhotics, for those who are waiting for transplant or even in donors. And this can achieve about 10 to 15 kilogram weight loss in a 6 months period. Here we are placing the sleeve over which we will now fix the balloon. It's very easy. It's just like putting in, here is the balloon in the hand. We are trying now to put, sorry, go back in. My apologies. So the balloon is now fixed over it and it will be placed. This is the endoscope with the balloon fixed on it. We place it inside and you can see here the balloon is gone in and this is finally the position of the intragastric balloon. Alternatively, you can also do bariatric surgery. Here you can see that gastric bypass will bring down the diabetic medications to nil in about half of the patients. Sleeve gastrectomy by about 1/4. So the people who lose weight by whichever method can have a reduction or actually no diabetes. Weight loss of 10% will achieve fibrosis regression in 4 out of 5. However, when you give advice, only 10% of the people achieve 10% weight reduction. 90% don't reach. So you need balloon or maybe bariatric. Exercise has huge benefit. You all know it. Still I am telling you there are changes in the liver. De novo lipogenesis decreases and insulin sensitivity increases. Visceral fat decreases. Supply to the liver of lipids decreases and VLDL clearance increases. On the heart and cardiovascular system, there is huge advantage. Myocardial damage decreases, the end diastolic volume increases, calcium handling and oxygen supplies. They all are beneficial. So remember, diet, exercise and weight loss have a relevance. There are several standard drugs. They are called for NASH. Pioglitazone has been the mainstay in the West. In India, we are using vitamin E, which is given for non-diabetic patients, but it is not recommended in cirrhosis. Also, more than 2 years and 800 milligrams can lead to problems like CA prostate. My favorite drug had been all these years is methoxyphyline. The basis of using this drug is long. I'll just show you some. I hope I have some data. Yeah. So pentoxy is a methylxanthine, decreases TNF-alpha and is a potent immunomodulator. In this first study, when it was done with Dr. Satpathy, in 6 months' time, the ALT levels came down. And this is the 2 biopsy pre and post. And you can see that the fat actually disappeared from the liver. Then we combined, this was Chandan's thesis, vitamin E plus pentoxyphyline. And this combination was much more superior to just giving vitamin E alone. TNF-alpha levels came down much better. So today a combo of vitamin E and pentoxy is superior and cheaper. You have now dual PPAR agonists. Of them, SARA is one where PPAR delta and PPAR alpha, PPAR gamma and alpha combinations are given. SARA glitazole has been found that it decreases the weight, it decreases the fat content, and because of these reasons, saraglitazole has been used. In our own study, which we did in India, of about 102 adults, biopsy proven, compared to placebo, there was a reduction in the NAS NAFLD activity score by saraglitazole to 52% of the patients compared to placebo. Future drugs include, which are under phase 2, but I think now can be used, is lenifibranor, and we also have drugs which can come, maybe semaglutide, which is being evaluated, Armcol, which is a bile acid fatty acid conjugate, and resmetirom, which is a thyroid hormone receptor beta agonist. Well, we have to wait. Obeticholic acid has been tried, but has not has been very effective. Remember, we will need combination of drugs. NAFLD with type 2 diabetes is a common. In our last survey about 3 years ago, at ILBS we had close to 2,300 patients who had diabetes and cirrhosis. It's a huge problem. The drug of choice is metformin. Additionally, you can give liraglutide or sitagliptin or SGLT2 inhibitors. These are now emerging very rapidly because they decrease ALT, intrahepatic triglycerides, help in weight loss also, and glycosodium. I want to bring it to attention to all of you that India is the first country in the world to integrate NAFLD into the NCD program. This was launched last year as a groundbreaking initiative. In this, guidelines to all the states where Government of India were given. What is the approach? Approach is at the community level, the ASHA worker can just ask history of 10 points in the family. Then they refer it to the primary healthcare physician. And this you can teach to all your nurses, compounders, or healthcare workers. They refer to the PHC. At the PHC level, they will find out and see those who are uncomplicated NAFLD, they can manage it. Those who require further workup are referred to the community hospital and then finally to the district hospital. Here you may do fibroscan, here you may do ultrasound. Because of this initiative of India, today India scores #1 position in the world as far as NCD assessment and management is concerned. India gets 49 out of 100, while UK and other countries get 42. So my carry-home message for you, my friends and physicians, is to define NAFLD. Clearly those who are obese, those who are diabetic. So obese, you have a management plan, Mediterranean, or I would say Indian diet, coffee, exercise, avoiding alcohol, and weight loss. If needed, intragastric balloon, vitamin E, pentoxifylline, with or without SARO, and GLP-1 agonist and obeticholic. Prevent HCC, screen them carefully. For those who are diabetic and have MAFLD, you have a clear pathway, metformin plus NA. In the lean, which are about 20% of normal weight, you have 3 to 5% weight loss, vigorous exercise, low fructose diets, and others. You have to screen for NASH, screen for cirrhosis, screen for HCC. 50% of the HCCs in MAFLD are non-serum. And of course, you have to prevent decompensation. Thank you for your kind attention.
Thank you, sir, for an excellent presentation and a clear message. Any questions for Professor Sarin?
So one quick question,
Yeah,
Dr.
please.
Lahoti, quickly to Dr. Sarin. So in his last slide, the carry home message slide in the diabetic population with MAFLD, I didn't see pioglitazone. So is there a reason for not having pioglitazone as one of the treatment modalities or options?
Very good question. I think all endocrinologists give PIO, but hepatologists have not educated themselves enough for using PIO. The drug of choice for us is metformin, but in the West, PIO has been the mainstay. But people are a bit scared of using PIO and hepatotoxicity, which in my mind is not a major concern. So one can use PIO very well.
Thank you, sir.
Sir, one last question that has come from the audience is that are we authorized to use these drugs, metformin, saroglitazar, pioglitazone, in non-diabetics with NASH? Can we write it comfortably without, or is it only off-label?
Well, the use of SARO has been approved by DCGI for non-cirrhotics, but not for cirrhotics. Use of metformin is very well for almost all indications of fatty liver and also fibrosis. Metformin is also used for cirrhotics unless they are decompensated or there is a fear of lactic acidosis. And it's a generic drug now, so you don't require, in my mind, any license. Metformin has 3 advantages, just half a minute. The stellate cells become quiet, so portal pressure decreases. The AMP kinase pathway is inhibited, so liver cancer decreases. And third, it works very well in reducing weight in some patients, besides its other sugar-lowering properties. So metformin is an antihypertensive for liver and a very good drug, and it is the drug of first choice in my mind for a diabetic with liver disease, unless it is decompensated.
Thank you, sir.
So the question is...
Sorry, the question is that you mentioned about gut microbe alteration. Is there any specific microbe that you want to alter?
Well, if you ask me, there is not a specific thing, but increasing lactobacilli helps. And varicola is the one which is beneficial, and it can be an acromyces also is one which is beneficial. So these two can be added. Bifidobacterium, there is some advantage of adding it. To be sure, one thing you can do is make people work on natural foods as much as they can, and that leads to release of short chain fatty acids like propionate. So vinegar is a very good model. Vinegar helps it. The second, you can have a short chain by giving legumes or sprouts, which are very good. They release succinate and butyric acid. I think these are beneficial gut stimulating foods.
I think we end the session and hand over Dr. Lahoti.
Yeah, I have got actually 3 questions from the audience on my phone. And the first question is for Dr. Duseja. Dr. Duseja, can you unmute yourself and can you appear live on video? So thank you for coming and joining us. He had a very
Good evening.
busy schedule. The question is that there are patients who are diagnosed as lean NASH, okay, and they actually expect that they should gain weight by way of treatment, and if you ask them to reduce further, they may be immunologically compromised because of already low weight. So how do you tackle these situations?
Thank you, Dr. Lahoti. At the outset, my sincere thanks to you and your team for this kind invitation. And as you just heard, Professor Sarin about, that around 20% of our patients or maybe 15% of our patients are so-called lean NAFLD or with normal BMI. So unfortunately, when we define these patients, we are still dividing them based on the BMI. We are not considering their waist circumference or central obesity into the picture, which should ideally be taken. Because there is a data to support that even if they are lean as far as the BMI category, they may still be centrally obese, and the pathogenesis in them still remains, majority of them still remains as insulin resistance. So when the pathogenesis is insulin resistance, so the treatment, even though they may not be required to lose weight, we have to improve the insulin sensitivity. And the best, medicine to improve the insulin sensitivity is nothing but a good physical exercise. The exercise has been shown to, improve insulin sensitivity, reduce insulin resistance, and thereby, even if they don't lose weight, I think has been shown to improve hepatic steatosis, both in lean and in obese people. But then there's some recent data which is emerging now in lean patients where that even if they lose, say, just maybe 3% of their body weight or 3 to 5%, histological improvement in other parameters like inflammation and fibrosis can also happen. So I think the answer to your question is that if they are worried about losing weight, they can simply be advised, good physical exercise, all the aerobic and the anaerobic exercises which were alluded to. But if they lose say 3 to 5% of body weight, it doesn't really matter. Rather, it will help in their histological improvement.
Yeah. Okay. Thank you. Next question is for Professor Sarin. Sir, you showed actually a balloon being placed to reduce weight in chronic liver disease patients. So my fear is that sometimes these balloons can worsen PGP and even induce bleeding from possible varices. So, and especially decompensated cirrhotics are a challenge population because they are obese and yet we don't have any means to reduce the weight. Your comments.
A very good question, Dr. Lahoti. So first we do a screening and see that patients have only cirrhosis with grade 1 varices, no gastric varices and no gastropathy. If they have gastropathy or large varices or gastric varices, they cannot be. Otherwise, you can put balloon, and I must say with experience of more than 200 patients now, it works well. Patients lose close to, some of them have lost 46 kg over a year. So it's a very helpful, simple method in compensated cirrhosis up to child B6. The group of patients we are now working and have some experiences of decompensated cirrhosis with a bilirubin of up to 3, but no varices or PHG. In them, there has been some advantage. The non-transplant candidate becomes transplant candidate over a or even out of transplant list. But they are little sicker patients. But in compensated cirrhosis or any non-cirrhotic, I think it's a very, very good modality.
So the last question is for Dr. Duseja. Dr. Duseja, there are patients whose families also come with the same kind of BMI. They are also obese. So is there any evidence in, especially in Indian population, that the family screening will help in defining or finding new cases among the family members?
Yes, absolutely. If you look at the earlier studies, I think there was some clustering described for initially what we used to be called as cryptogenic cirrhosis. And then, came the story about the genetic basis of fatty liver disease. So there is a genetic basis and the genes, various genes which are involved in the pathogenesis. So that's the genetic basis for, family screening if you wish to do that. And as I said, family clustering has been shown. But more important than that is that the environment for these patients or the families are obviously together. They eat together, they eat same food, and they may have same kind of, physical activity or for that matter, physical inactivity. So I think there is good data to say that yes, I think if there is one family member who has NAFLD, the chances of having NAFLD in other family members are definitely high for two reasons, as I said, common environmental factors and there could be a genetic basis also. So I think there is no harm in screening, but then if you ask me, frankly, if there are any guidelines like that, I think we don't have guidelines for familial screening, like say other hepatitis B or say other viral infections. But then there are data which are coming up now where people have suggested now that we must screen people, those who are overweight, obese, diabetic, or with metabolic syndrome. So on the same basis, I think if you have, family members who are having, say, these metabolic risk factors or say fatty liver disease, there is no harm screening. But as I said, we don't have those guidelines.
I think it's my duty to thank Professor Sarin, Dr. Duseja, Professor Duseja, for sparing their valuable time on behalf of Easily Physician Association. Sir, I thank you both. If you were here in person, we would have certainly been more happy. Let's make it next time. Thank you, sir. Thank you.
Thank you, Deepak and Naresh. Thank you so much.
Thank you. Bye-bye. Bye-bye.
For the next session, I would like to invite Dr.